thank you all for coming. This has become a sort of an annual event to have a Veterans Day themed event, because Veterans Day is this weekend, and we've traditionally had a talk that related to the Army during their time here on this campus for in celebration of Veterans Day. And for the past several years, we've had Dr. Rich and Don Hall collaborate and give us some Army medical history. And this time we keep progressing through the years, and we're up to 1965 and going forward. And unfortunately, Don got shipped out of town at the last minute, so he won't be here. But Jean, you're in good hands with Jean giving us that talk. So take it away. Thank you.
Thanks. And indeed, it looks like it may only be me. Andrea Schierkolt from the National Museum of Health and Medicine was going to try to make it by, but I don't see her. But I will mention their museum at the end. And even though Don is not here in person, he contributed a lot to the slides and a lot to the materials, although anything that I say that's wrong is really entirely my fault. Nonetheless, Don always likes us to remind folks that the views expressed in these slides are our own and do not reflect the views of the Department of Defense, who's Don's employer, Mathematica Policy Research, my employer, or anybody else at Save Our Seminary. So, and the objectives of this series have been to consider how medical technologies and treatments evolved during the Army years and the role of Forrest Glenn in these advances. And we use archival materials, publications, and photographs, although not too many photographs tonight, sorry. So, and this, we're going to be talking this time about the Army in Vietnam. Now, for those of you who were here last year, Don introduced the U.S. presence in Vietnam, but we ended in 1964. And this time we're going to be talking about the beginning of 65 to the end of 68, which, as you can see here, is the entire period of the ramp up and the peak in U.S. military presence in Vietnam. So in and this is material that Don provided. Sadly, if you ask me any questions about these details, the odds are I will not be able to give you correct answers. So, so apologies for that. So as Don noted, the first major troop deployments were in 1965, and in 65 was the Battle of the La Drang Valley, which I understand from Don was the first time that there was a major engagement between regular North Vietnamese Army soldiers and the U.S. military. In 1966, there was a major expansion of the medical footprint to support the increasing combat, and more than 12,500 soldiers are in the medical brigade at its peak, which was in 68, and then there were also medics assigned to all the field units. Key dates in 67 to 68, well, in November of 1967, General Westmoreland at the National Press Club in D.C. said the end begins to come in sight, and then we have Tet, which was the new year in that part of the world. And as Don indicated, that basically Tet was Happy New Year, U.S. Military Assistance Command in Vietnam. And the Tet offensive went from the end of January into March of 1968. And as you can see from this graphic, it involved it was preceded by major movements of regular Army from North Vietnam troops through countries like Laos, and then projecting force into various parts of South Vietnam. And some of you who remember that time will remember that then that resulted in bombing of other countries like Laos to stop movement of troops and material. So then in February, remember the Tet Offensive now has been going on for almost a month. Walter Cronkite has a CBS special in the Vietnam War and says that the U.S. is mired in stalemate. You know, and some people have said that this was, well, LBJ had lost Walter. In March, there are various college campus protests. In March 31st, LBJ says, I will not seek re-election. And then in April, we have the assassination of Martin Luther King. June, the assassination of Robert F. Kennedy. At the end of October, in the midst of a presidential campaign, LBJ orders halt to all air, naval, and artillery bombardment of North Vietnam. But in November 5th, former Vice President Nixon beats Vice President Humphrey for presidency in a very narrow popular vote. So a lot is happening overseas. Almost 3 million Americans served in Vietnam. 47,000 were killed in action. 11,000 almost died of non-hostile causes. Over 300,000 wounded in action. 150,000 soldiers were hospitalized in Vietnam. And they only left the country if injury prevented return to work in 30 days. And while most wars, and the war in Vietnam is mostly a story about men, women played an important role here. There were over 7,500 service personnel who were women, mostly nurses at that time. 8 American servicewomen died in Vietnam, 1 to hostile fire. And that was First Lieutenant Sharon Lane. And she was killed moving Vietnamese patients to safety during a rocket attack on her hospital. And she was posthumously honored with the Purple Heart and Bronze Star with V for Valor. So that's a little bit of the background of what's going on overseas. Now, what's going on here? So this is an aerial photo. You folks saw a different version of this that Don had prepared before. And the big thing that's happening in March of 1964 is the Beltway, which you can see up here. And I'm going to come back to this in a minute, but things in 1964 have become very quiet from a military healthcare perspective at Forest Glen, possibly as quiet as they've ever been here, at least since the 1950s. Just to orient you, here's the ballroom, here's the gymnasium, that's the old warehouse, there's the villa, they're tucked up against the Beltway. So that's to orient you a little bit. So that's in '64. Now what I'm going to do is go through what records we found, or Don found, I should say, at the National Archives related to annual reports of what's happening here from '65 to '68. And the reports are pretty limited. And Don says that this has been true for most of his research, that once we get into the Vietnam War era, we had what the President Johnson called guns and butter strategy. So we were going to have a war in Vietnam, but we were going to not raise taxes and we were not going to cut a lot of other spending. Well, that ended up putting a lot of pressure onto the military. And you're going to see in various of these reports, they're really trying to do a lot with not more money. And as a result, the administrative interest in things like writing lengthy reports goes down. And so the amount of information that we get is even more limited. But we have some, and I've tried to string it out into some information for you folks. So in 1964, again, when building the Beltway, things are quiet. The bed capacity here is only 176, and the occupancy rate is half of that. So this is the lowest that it's been since we've been tracking beds since the 1950s. In 1965, we see a sign of this sort of limited documentation. Well, we've had no change in the mission during 1965, so that's about all they said in terms of any activity here. I can't tell, well, what clinical programs were here, et cetera. They do say Forest Glen section is a vital auxiliary to the Walter Reed Army Medical Center, providing facilities and logistical support. Not that they would tell me what they were. They do mention We have components of the Walter Reed Army Institute for Research, which we talked about last time, and the U.S. Biomechanical Research Laboratory, which was the updated name for the prosthetics laboratory that we identified that was here starting at the end of World War II. And I'll come back to the prosthetics laboratory at the end of this talk. Now, bed capacity has increased to 261, and they say they added 67 beds on Ward 125, and I'll come back to that in just a second. And the bed occupancy rate has gone up a lot. It's almost doubled, as you can see, and that's just in 65. Now, Ward 125 is not really as a ward on any of the maps that we've been tracking in terms of patient care wards here since the 1950s. Now, this is a map that we found from 1951 that is of the entire complex in 1951. Just to orient you, there's the ballroom, there's the fountain, etc. We're, here. So there is a building 125. That's the stables. That weren't stables at the time, but it seems like that would be awfully far away from any other health professionals to have a patient ward. So was that Ward 125, or is it somewhere entirely different? Yeah, I could certainly imagine that prosthetics was... That's where the lab was. Yeah, that's right. Thank you for that. So we're told by someone who was here in 1965 that that's where the prosthetics lab was. That sounds plausible. So unfortunately, this is the first signal that we've got patient wards being expanded here, but I don't know where they're located. All right, the report from 1966 says there were some troop command billets, a rare administrative area, and a USAIDR facility that were converted to patient wards. I'll come back to that when we look at maps. Refers to wards 100, 111, 112, 113, 114, renovated, equipped with new beds. Again, our old maps of where the patient care wards are, none of them refer to anything with these numbers, as you'll see in a minute. But the total bed capacity has now gone up a lot more. We're up to 408. Oh, by the way, building 117 is condemned and raised and paid for parking. Let me show you that.
For frame of reference, what would be a capacity of a hospital in the area?
Oh, well, I would say that Walter Reed main campus had like 1,000 beds. Okay. Got to remember that back then, patient occupancy rate was a lot longer. Hospital stays were a lot longer. We'll come back to that. This, however, was not, and we'll come back to this, was not an acute care hospital. This was essentially a rehabilitation hospital. So the length of stay here would typically be much longer, but it was a selected group of relatively less acute patients. Good question. And I didn't bring it today, but we have statistics from in the 50s of the hospital bed capacity at the main campus, and in my recollection, it was over 1,000. So building 117, which was torn down, is the building that connected to the Aloha House and the gymnasium, which are here. And those of you who know the story here know that there was a time when there was a covered walkway with a glass canopy that connected the Aloha House and the gymnasium and also connected this building here. So now we know from that report what year it was that building, and was that called, what was the name of that?
Recitation House.
Recitation House, thank you. That's when the Recitation House got pulled down. It was 1966. Now, we do have buildings 111, 112, 113, 114. That is the Cape Cod House, the Swiss Chalet. That's like the library, right? And that's the chapel. They're kind of far away to be patient care locations, and I always thought that most of those were used for officer housing at the time. So again, I don't think those are these wards, but at least it's kind of an interesting mystery. 67, the Army Community Services Branch Office moves to the Forest Glen section. And I tracked down some information. In the bustle, I ended up loading the wrong slide deck, but I can work from this one. So you'll just have to trust me that I tracked down that. Army Community Services, at the time and still today, and other folks can correct me, but my understanding is that this prepares folks for transitions from their current location. It does family support, helps folks with financial planning, with planning for job searches, things like that. So the fact that they've moved something here would suggest that, that because of this expansion, they're providing more services to the soldiers and their family members for transition. And steps regarding a fire company. There have been some embarrassing fires. There was a bridge that burned up, and you'll see some more action on that later. And the patient census is now 291. And now 1968, which is the end, we have a census now up to 360. That's 69 more a day than even in 67. Social work has created a whole unit here, again, probably to help with transition. There's enough going on here that there's a new medical holding company officer here. Shortage of personnel is a major problem. The report notes that they are assigning more responsibility to patients. So for example, at each ward, there's a non-commissioned officer and assistant among the patients who are assigned to do things like clean up and replace light bulbs and stuff like that. And if I don't know, Frank, did we already know when the fire department was first started here?
I personally was completely ignorant.
So, well, their fire truck arrived in January of 1968. So, now looking at the Walter Reed General Hospital report, I don't have any Walter Reed General Hospital reports from 65 to 67. This is the Georgia Avenue location. But I do have one from 68 that Don found. Those involve reports from the commanders of each of the clinical departments. So Department of Internal Medicine, Department of Surgery, Department of Psychiatry and Neurology, et cetera. Various clinical department reports note inadequate space and facilities, but this report that's written at the end of 1968 says there is a 5-year plan that includes a new Walter Reed General Hospital. So that's the first reference I see to that. Now we know that will be completed in 1977, and its completion will substantially change what's happening here on the main campus. So the first sign of planning for that is mentioned in this 1968 report. And they also mentioned plans to expand the Walter Reed Army Institute of Research at Forest Glen. And of course, those of you who are familiar with that know that its main footprint has now been here for many years, although I think they didn't arrive until after 77. And then the Department of Psychiatry and Neurology report, again, at the George Avenue location. Unlike the reports from the 50s, where the clinical departments at the main campus would refer to things happening here, all of the clinical departments at Walter Reed General Hospital on the George Avenue campus do not talk about them having any responsibilities here. And I may come back to that later. They focus exclusively on activities there. They do note research collaboration with Walter Reed Army Institute of Research, which we know the psychiatry research was located here. So that's sort of a snapshot of going through those reports and seeing what we know and what we don't about what was happening here from 65 to 68. Now what I'm going to do is quickly go through the maps of where the wards were. And again, recognizing that there are a bunch of wards now that they have activated or refurbished that I don't even know where they're located because their numbers don't show up on these older maps. Just to orient you, again, this is from Don's aerial photograph that he tracked down, but this is all expanded. Now I flipped it around so that the beltway is here and the villa is here. So we'll see if you guys can imagine this, because it's all a little hard to see. In fact, I'm struggling at the moment. Yep. So there's the fountain. There's the ballroom. There's the senior house, senior annex. The Odeon would be there. So that's the orientation. So that's to sort of help you understand. These maps are basically that orientation. So ballroom, senior house, senior annex, etc. So the basement of the ballroom is a patient ward, and the lower levels have senior. I don't know what's on the lower level there at senior annex. We know that the Institute for Dental Research is there in the lower level. Now this is the first floor. This is in 1965. The report from 65 shows that a women's patient ward that looks like it may have been for GYN patients has moved back to the main campus, and there's now a neuropsych open ward in 66. So this confirms that there is at least care of psychiatry patients happening here still in 1966. And you can see that some of the facilities are for enlisted personnel. Now in 64, last year we talked about the medical specialists at advanced course, and we can come back to that if we have time and people have questions. But we reported that in the end of 64, this moved to Fort Belvoir. So that space is vacated. And what moves into there is a bunch of administrative work. So that is not patient care. And we know that Walter Reed Army Institute of Research had a variety of facilities here that we talked about at the last time. 68, some of these administrative activities move. Now, I never understood, Anne, what plans and intelligence meant, but whatever it was, it only became intelligence in 1968. Plans moved back to the main campus. That's the kind of very limited information you see in these reports. It's like, somebody understood what that meant at the time. I can't tell. And the report also mentioned that they scaled back administrative space for the Army Institute for Research. So maybe that was their departmental space.
Can I ask a question?
You bet.
What if 161 is where we're sitting right now, right? The clinical and sensory psychology?
It was second. It would be first floor, though, right?
No, I thought it was second. I'm sorry.
Aren't we on the first floor?
So for this purpose, we're on the first floor.
Yeah. And this was not a patient care area. We're talking about one floor up. Yeah.
So this was upstairs.
So 161 is over that way. And remember, the dental clinic is off there. And back to the dental clinic, the dental clinic is mentioned in reports in 65, 66, and 67, but not 68. So now the third floor, so one floor up, back in 64 again, we had male student billets related to the medical specialist advanced course and more teaching space for that course. Again, that gets vacated in 65. And that becomes Troop Command billets and the Walter Reed Institute of Nursing, which I'd never heard about before. Now, it turns out that the Walter Reed Institute of Nursing, in '64, the School of Nursing signed a contract to provide baccalaureate nursing education for the Department of the Army. In '66, the first students entered the Institute of Nursing program in DC. '68 to '78, 1,100 women and men graduated. And Walter Reed, this is a report from the history of the Walter Reed Institute of Nursing. This institute differed from other nursing programs because it drew students from across the nation and attracted large numbers of males and large numbers of African Americans. And more on a report that I tracked down. So in '68, they were just getting started. So they'd created space, but they weren't, didn't have much in the way of students. By '72, you can see they had a lot of students, but also by '72, all of this seems to be on the main campus, because Delano Hall is on the main campus of Walter Reed, not here. So at some point after '68, the Walter Reed Institute of Nursing moves out of here. And then we also get this statement in '66 that male enlisted billets that had been here are moved to the main campus to provide space for patients and for WAC company personnel. So again, this whole big area is now turned into, at least some of it, into patient space, but I don't know what. And I suppose it's possible that this is these other wards that have been renumbered and we don't know about. So just don't know.
What is the term billets?
Billet, I believe, is basically, that's where you're bunked. It's where it's your living space for a soldier.
Patients or non?
No, these would be non-patients. Yeah.
And WAC?
WAC is Women's Army Corps, right? I'm sorry, I should have said. Yeah. So that is a real quick movement through sort of what we know about the facilities here. Now I'm going to talk about medical care at the Forest Glen Annex. This other stuff is really the stuff that Don is the expert about. This is the stuff that I'm supposed to be an expert about, except that I've already warned you, they tell us nothing about what medical care is being delivered here, except I know there are neuropsych patients here, and I know they have an open ward, so they must not be acutely psychotic, but that also makes sense based on some other information I'll share with you in a minute. So what I can tell you is I'm going to speak first to what we know is going on nationally. So this is a report on selected causes of Army hospital admission from '65 to '68. And these numbers are admissions per 1,000 soldiers in uniform. So the numbers look small, but you got to realize this is per 1,000. And what you can see here is, this is not surprising, from '65 to '68, the number of wounded in action doubles. The number of cases of malaria actually goes down, which would suggest that they're doing a pretty good job of prophylaxis to prevent cases of malaria. So that's good. Neuropsych is blipping up just a little bit. It wouldn't be statistically significant, but we're going to come back to that. Viral hepatitis is going up. Well, viral hepatitis is endemic in Southeast Asia, but there might be another reason why people are getting viral hepatitis if they're soldiers in 1968, and I'll come back to that in a minute. So this is overall statistics for what's causing soldiers to end up in the hospital during this period of '65 to '68. Now, the Walter Reed Department of Psychiatry and Neurology provided some interesting reports about what they're doing on the main campus. So that's not here. But they report that they reorganized in '68 to limit hospital stays for those who only require short-term treatment and evaluation. They're having pressure on staff, they're having pressure on facilities. They need to try to turn people over so they're not hanging around the hospital that long. So They set up a special unit for those who require short-term evaluation and treatment, intensive wards for the seriously ill, and then a rehab ward for male patients who can be returned to duty or discharged from the Army. They use a treatment model that's educational on this rehab ward, and this is sort of like what we heard in the 1950s too. They're using sort of an education, learning about your illness, sort of psychodynamic approaches to psychiatry. Patients requiring long-term therapy are transferred to other wards. I'm guessing that includes here. So again, long-term acute therapy and initial stabilization, getting them ready to go if they can be discharged or they can go back into the military. They're cared for by neuropsych on the main campus, and then if not, they're discharged. This program materially reduces the length of hospital stay for the average patient, they note, although high patient census and bed space continues at a premium. Again, they've got lots more soldiers who are sick. They're trying to not spend more money here, so this is resulting in a lot of constraints. And frankly, a fair fraction of the prose in all these reports is devoted to talking about how much they need more stuff. It's clear that there's a message that everybody's trying to convey to the brass as they write these annual reports now, which is we don't have enough. All right, what about psychiatric conditions Army-wide? So 65 to 68, you can see from a baseline of 65, all these years, once Vietnam kicks in, admissions for psychiatric conditions go up, both for psychoses and for psychoneuroses. And there's a looming problem here, which is neuropsych hospital admission rates in Vietnam will more than double from 65 to 70. And unlike World War II, neuropsych admit rates rise, although the combat role is going down. Because remember, Johnson indicates we're going to stop bombardments the end of 68, and then we're in peace negotiations in 69 and 70. So the combat role is going down, and if you remember those force projections, they're going to fall off steeply after 1969. So the combat role is going down, but psych admissions in the Army are going up. Why is that? Well, maybe drug use and abuse. The ready availability of marijuana, barbiturates, amphetamines, heroin, and even opium in Vietnam. In fact, I found a 1969 study that suggested over 70% of soldiers in Vietnam tried opium at least once. So that's sort of foreshadowing what's going to be happening next. But this is just sort of a signal of a problem in 68. Now, the other thing that we talked about a couple of years ago, folks will remember that I found some detailed statistics, more detailed than this, of psychiatric diagnoses for the Army in the 1950s, and most of the terms I didn't recognize. And I went to medical school, learned psychiatry in 1976, and been practicing. I know psychiatric diagnosis. I didn't know these. I don't even know what a psychoneurosis is. That was not a term that I ever learned. So what was that all about? And the other thing that's interesting in doing my research, it turns out that the first diagnostic and statistical manual that was published in 1952 was actually built on World War II Army efforts to express present-day concepts of mental disturbance. The problem is that the original diagnostic and statistical manual used psychodynamic psychiatry, Freudian and post-Freudian diagnoses. So, for example, they classify people by different styles of schizophrenic reaction, whatever that would be, and they say, for example, that the schizophrenic reaction can be understood as attempts to reach a psychotic adjustment to life by way of delusional distortions. So they're looking at schizophrenic patients who think that aliens are beaming messages in their head, and rather than thinking maybe there's something organic wrong, they're thinking that they're somehow adapting to poor upbringing by these delusions. It's really sad, but this was the way people understood psychiatry and were diagnosing it in the 1950s. And lo and behold, they're still doing it in 1968. The DSM-2 uses essentially the same structure. But in the early 1970s, researchers at Columbia and at my alma mater, Washington University, are saying these diagnoses are unreliable. Doctors can't consistently place people into these categories. And so by 1976, my professors at Washington University are saying, do not learn that stuff. You're learning this new approach that we'll talk about more next time. But so there's evolving standards of evidence in psychiatric diagnosis that are sort of on the horizon, but they're still not there yet at Walter Reed in the Army in the 1960s. One of the things we touched on last time that is going to have a big impact on the need to come up with new ways of diagnosing illness, and I'm going to explain why in a minute, is that there are new, more effective medications for psychiatric illness. The 1950s, we described the development of the first antipsychotics, the first effective antidepressants, and a whole new class of what were called at the time tranquilizers, the benzodiazepines, the first one being Librium. So now you've suddenly got potent, new, entirely different kinds of medications to treat these patients' illnesses in the 1950s. And just from 1965 to 1968, there is a dramatic increase in the availability of drugs. We have Valium has come on the market. By 1969 is the top-selling drug in the US. We have new antipsychotics. I'll come back to this in a minute. Flufenazine, haloperidol, chlorprothiazine, which I can't pronounce because this had sufficient toxicity that it's now no longer available in the United States. Thiothiazine, protriptyline is an antidepressant. Carbamazepine or Tegretol was originally FDA approved for epilepsy and trigeminal neuralgia, but it becomes important in treating bipolar disorder in the 1970s. And lithium is an interesting story. It was actually being reported and used for maniacal psychosis, whatever that is, in the 1950s in Australia. And then it starts getting used in Europe. It's not until the mid-60s that you start seeing reports in the US literature of using lithium for what's called manic psychosis in those papers. Then it's approved for use in the FDA. And I'm going to come back to lithium in a minute because that's kind of an interesting story. So suddenly, we've gone from having, really kind of strange therapies that don't have a very good evidence base. Professor Gallagher and his controversial technique of simultaneously confronting fear of heights, snakes in the dark, to extremely potent but toxic medications to treat some of these terrible illnesses. And so this may promote a new approach to thinking about diagnosis and treatment in psychiatry. And so I'm going to wrap up by a brief reminder of how our standards in the West of evidence related to doing things to patients has changed over 2,000 years. So those of you who were here a few years ago will remember that in the ancient to medieval times, we relied on authoritative texts like Hippocrates and Galen, and treatments based on a theory of disease. The one that you may be most familiar with is the four humors: blood, phlegm, yellow bile, and black bile. And if you diagnosed people as having an excess of one of these, which you treated by, getting rid of that or providing more of something else. So you treat excess blood with bloodletting. Treat excess yellow bile with emetics, make them throw up. Treat excess black bile with cathartics, give them diarrhea. Treat excess phlegm, because you're too cold, with something that'll give you a fever. Fever therapy will come back in a minute too. But then we've got the Enlightenment and the empiricists. And here we have a major emphasis on the idea that it's observations and sensory experience that are the primary source of knowledge. Now, back in the 1940s, Don and I reported to you folks a few years ago a case series that was still going on at Walter Reed main campus in the 1940s for neurosyphilis. They were able to reliably diagnose neurosyphilis. The problem is that neurosyphilis unfolds variably over years. And they were treating them with fever therapy. This is almost back to the Middle Ages. They would raise people's temperatures to 105 degrees and keep them there for more than 5 hours. They had a theory for why that would work. The spirochete that causes syphilis doesn't like being hot, so they thought that it was, might do worse than the people would. And their follow-up approach was to simply write the patients a letter a year later and ask them if they felt that they were better. You can think about all the problems with that. So that's the first level of evidence, is case series. Now the advance moves into comparative case series. The classic is the Semmelweis work on puerperal fever, and noticing that by washing hands in one of the two clinics in Vienna, the rate of puerperal fever just dropped to vanishingly low levels. Unfortunately, I'll come back to the problems with comparative case series in a minute. But we stopped doing bloodletting for pneumonia based on a comparative case series. Patients who got bloodletting and a comparable concurrent group of patients who didn't. And the patients who got the bloodletting with pneumonia didn't do as well. We stopped doing digitalis in patients with pneumonia, the same kind of evidence. In the 1950s, we stopped doing insulin coma to patients with acute psychosis because of comparative case series. So that is evidence that can work. The problem is, and the Semmelweis case is a good example, the other doctor said, well, how do you know it was the hand washing? You had 2 patients in 2 different clinics. Maybe the patients were different. Maybe the other care attendants were different. Maybe the skills of the practitioners were different. You don't know that it was hand washing. I'm sure my hands are just fine, thank you very much. And so he was ignored for 20 years. And oh, by the way, you're nuts. You're obsessed with this. I don't even trust your data because you were the one that wrote it down yourself, and you're crazy, and you think that magically washing hands makes a difference. So you had all these problems with other questions about comparisons, plus concerns about observer bias. So comparative case series can be better than no evidence, but they can be pretty weak. So it's in 1948 that the Medical Research Council in the UK does the first randomized controlled trial. So we take a group of patients who all have a consistent condition, pulmonary tuberculosis in this case. We randomize one group to get streptomycin, the other group doesn't, and then we see who gets better from tuberculosis at a better rate. That's the first published human trial that's a randomized controlled trial, and that's a standard of evidence for many studies today. First done in 1948. Now in 65 to 68, we're seeing a significant increase in the use of randomized controlled trials in psychiatric illness, which sort of goes along with the fact that we've now got these potent drugs. So we've got a randomized controlled trial comparing treatments in depression, showing that amitriptyline and electroconvulsive therapy work better than placebo and sham ECT. One of the new benzodiazepines is tested compared to placebo in the treatment of anxiety. And this brings up more issues about how to observe things systematically. There are self-ratings from the patient that favor the drug. direct observations of patient behavior are no different. And the scientists at the time are puzzled about what to do with that. And then flufenazine, this was a drug that was really a mainstay in treatment of chronic schizophrenia in the 70s and 80s, shows that a long-acting agent, if you do it every 2 weeks, controls clinical behavior of hospitalized schizophrenic patients, and withdrawing the medication in a randomized way led to a regression of symptoms. So some emerging standards of evidence with respect to schizophrenia. And finally, we have something new. At the end of the 1960s, you say, well, okay, we're now criticizing all these studies. Well, maybe we need to look at more than one. And we have the first critical appraisals of the whole literature. So we get them all together, and we take a look at what these group of studies tell us collectively. And there's this debate about the role of lithium. And you can see this, there's a series of articles that debate the role of lithium in the British journal Lancet. It's become increasingly popular because of a supposed prophylactic action in manic depressive psychosis. But the evidence to date lacks clear criteria for selection of patients. Remember this problem with, diagnosis that nobody can agree on. Picking patients, picking who should get the prophylaxis and who wasn't going to get it, not consistent. Faulty evaluations, observer bias, the Semmelweis problem. How do you know, what was being observed here and that it was unbiased? So the conclusion is we need a controlled double-blind evaluation of lithium. Indeed, there are 3 published in the early 1970s. It's FDA approved, now a mainstay for management of bipolar disorder. So during this period of the 1960s, there was a lot happening to try to help medicine men and women, when they're reading the latest Journal of the American Medical Association, come up with the outcomes they want, presumably rain in this case, rather than egg beaters. But, there's still a long way to go, but there are at least a few signals. And even though we don't know exactly what they were doing in 1968, we do know they always had the latest medicines available at Walter Reed. We do know they had neuropsychiatric patients here. So I'm thinking that all of these insights, all of these studies would be actively talked about here in the 1960s. So next steps, we're going to continue to locate and review detailed reports.
So the patient records have been trashed?
So far as I know, they have been, yes. I'm also, because I'm a faculty member at the Uniformed Services University and on staff at Walter Reed National Military Medical Center, I'm now trying to track down 1970s hospital discharge statistics. However, signs aren't good that they saved things after they moved to their electronic health record in 2000. So, I'm going to try. But we are going to look at 69 to 76 next time, which is basically up through the wrapping up of clinical care here, because in 1977, all the patient care here ended because of the new hospital. We also have the Army Prosthetics Research Laboratory, and this is my pitch for our neighbor, the museum. They have a wonderful collection of materials, drawings, designs, and actual examples of the various prosthetics that have been developed. So if anybody's here is interested in physical therapy or occupational therapy and would like to help us research that, that would be great, because prosthetics were a very big deal here, starting from the 1940s through the 1960s for sure.
And where is the biomedical research lab now?
I have no idea. I don't know. The Walter Reed Army Institute of Research is here, but I don't know where that is now. And that is the National Museum of Health and Medicine, which is just sort of across the street that direction. So that's it from me. Sorry I took so long. Happy to answer any questions.
That was very